Well, good afternoon, everyone, and welcome to the next iteration of Spry Webinar. Today, we're honored to have Scott Hebert from Secondary Health. I'll introduce Scott, and then he'll introduce himself. So Scott is a doctor of physical therapy, a successful startup founder, category creator, and a lover of all things buffalo chicken. Excellent. He is also just been on the forefront of innovation in the physical therapy field and for the last 10 years on the mission to change how physical therapy can better save the world. I think it has been an immense pleasure of working with Scott for close to a decade now. And I think what he has done to our industry cannot be described in words. But with that, I'll leave the mic to you, Scott, and go ahead and introduce yourself.
Thanks, Alex. Always happy when we get the buffalo chicken in there. I think it gets underappreciated. It should be a food group in and of itself. I don't know if RFK got that one in there, but I would have lobbied for it if it was. It's too good. But thanks for the kind words. My background is as a treating therapist by trade, but I often joke it's really only by diploma only. I've pretty much spent my entire professional career inside of health tech, but always building tools for physical therapy. Got my start with a company called Strive Labs, which was acquired by WebPT back in 2017. We kind of established patient relationship management as a category in PT. Brought in concepts like how to use Net Promoter Score to better manage patient dropout in care. A lot of things around marketing automation, and that was kind of where we got started. That product was used by about a third of all outpatient therapy practices, which was really fun and an honor to collaborate with so many great groups. A few years back, I left WebPT and set out to start a new company called Secondor, and we'll talk a lot today about kind of how that came to be and why, and we'll get into the specifics of this direct care motion and specifically direct to employer.
And I think that's perfect. And again, it's such a pleasure to have you here because I think it's such an important topic to cover. And part of it is just the overall confusion. So why don't we start off with just differentiation? I think a lot of people see direct employer offering as something that either contradicts fee-for-service or conflicts with fee-for-service. So can you just explain what direct employer offering is and how does it fit the overall musculoskeletal model?
Yeah. So, direct to employer care is exactly what it sounds like. It's a mechanism of going out and contracting directly with local self-funded insurers in a local community. Ultimately, there's a ton of value that physical therapists can have with employers, and the models. There's a number of different models, some of which look really similar to fee-for-service. But I think ultimately, the place to start with all of this is just why exploring these models, even make sense or are important right now. And I think, highlighting why physical therapy practices are primed to have a meaningful role in this approach. You want me to dive in on kind of the why behind all of this?
I think that would be awesome, especially like the big why and the little why.
Yeah, I mean, the big why ultimately comes back to margins. It does not take a rocket scientist to know that if you've been in or around a physical therapy practice over the last 2 decades, it's gotten harder and harder to run an outpatient PT practice, especially. And the realities are that what we've seen is kind of unprecedented margin compression across the industry. Depending on where you look, you've seen anything from, going from 20% margin down to low teens. Some places you'll see even single digit, and that's creating a lot of pressure. And the reality is that reimbursement rates have not kept up with inflation, and the cost of running a practice, whether that's wage inflation, whether that's just the cost of rent and other fixed assets, it's squeezing margin more than ever. And you continue to see additional administrative burden, and again, preach on the choir for any practice owners that are here today or watching this. That has really forced a lot of practices to kind of pick their head up and look to say, man, there's probably got to be a better way.
Yeah, I think it has to be a better way, right? We've been doing the same thing for decades, and without any innovation, we're not going anywhere. So I think why don't we go back just one step and outline what is the overall musculoskeletal cost to self-insured employers? Like what are we trying to do? What are we trying to save? And why is it so important? to get to that point?
Yeah, well, here's the prime reason, right? I mean, when you look at why has reimbursement not really kept up, the simple baseline economics theory, the way to look at this is that there just isn't historically alignment between what physical therapy does and the ultimate fiduciary, which is the insurance company. You could make the controversial argument to say they actually want the cost of healthcare to go up. And because of that, it actually puts conservative care providers like PTs behind the eight ball. And so you have to say, well, like, where does that alignment exist? And the place that alignment exists really is with the folks that have to bear the brunt of musculoskeletal care spend. And the really interesting thing that, I don't think a lot of people actually know, it's shocking kind of how many PTs don't really realize it. The conditions we treat, musculoskeletal injuries, aches, sprains, pains, is a top healthcare cost category for entities that bear financial risk. And there are thousands, tens of thousands, hundreds of thousands of actually self-insured businesses in the United States who, because of the cost of insurance and premiums rising, have chosen to go to a self-insured model. And in that model, they bear financial risk. They're not paying premiums. They're actually paying out claims. So for them, they have to look at their spend and they have to say, what's driving that cost? What's driving it up? Well, lo and behold, musculoskeletal conditions are basically always in the top three. And most employers we've talked to thousands, will state musculoskeletal as their most expensive cost category, right? Basically, MSK, cancer, heart disease, diabetes, right, are kind of your top three. MSK is always in there, right? Sometimes it's number one, sometimes it's number two, sometimes it's number three. Regardless, every employer recognizes they have an MSK cost problem and they need to fix it. And what I just described, that's the raw claims costs, right? That's just the actual, the cost of care delivery. But there's also indirect costs that also drive this up. So as we've highlighted here on the slide, musculoskeletal care is one of the leading drivers of disability and time away from work. And that has a massive impact on employer spend. And so both the direct and indirect costs really balloon for employers, making musculoskeletal conditions a really core focus area for them to help resolve.
Yeah, and how is, like, I think it's so important to even discuss how is the path dependence contributing to this, where like what you're trying to do, which is create a direct path towards musculoskeletal care. Yeah. And what is it like the traditional trajectory, and how are we changing it by having a second door that really modernizes this process?
Yeah. Well, I mean, we'll touch on it in a couple of slides, but I think it's good to call out right now. I mean, what's driving this cost up? What's making this expensive? It's not PT, despite what the payers love to tell you when they tell you your rates are staying the same year over year. We've now run hundreds of claims analyses for employers. We have never seen physical therapy cost more than 2% of plan spend, right? It is rarely, and kind of want to say rarely, it is never the primary driver of musculoskeletal care cost. What's ultimately driving the cost is the high ticket items. It's surgery, it's imaging, it's injections, and it's pharmacology, right? It's opioid and other medical pathways. And because of that, there's this massive opportunity for therapy practices to interject themselves earlier in the process to really become that first point of access and first point of care. And that is what's really kind of driving this motion. That's what's putting that alignment in place and offering a great opportunity, to explore these models.
Yeah, absolutely. And if we can then discuss a little bit about what is the exact structure, what is the differentiation between self-insured employers and someone who is not self-insured, right? So why don't we just even paint a picture of who are these self-insured employers and how does one find them?
Yeah, this is really important to understand, because at its core, this is what's driving the whole model. When you are providing an employer benefit, right? So anybody that's on the call or listening to this, that's an employer. You're providing health insurance in some form or fashion to your employees, right? And as employers get bigger, they start to recognize that those premium costs, man, if they just took those premiums that they spent and they put those dollars in a bank account, there's a decent chance that that total aggregated premium cost is actually less than they paid on medical care directly. Or at the very least, they recognize that they could get a way cheaper form of insurance. It's called stop loss. That could cover the crazy expensive outliers that are few and far between, and in return end up actually ahead by paying the claims. And so that is like what's driving, and that is the core of what being self-insured is, right? It's this model where an employer says, hey, I'm going to go ahead and I'm going to be the bank account. Like, taking one step back, I always tell people, like, if you think about what an insurance company actually is, it's a bank account and it's an administrative layer, right? It's a lot more than that, but those are like the two core categories of what happens. When a company decides to go self-insured, they say, we'll be the bank account. Okay. Now they still might partner with an insurance company to have access to a network of providers to, handle third-party administration of provider payments and adjudication. They may still have things like stop loss and other component elements of their overall plan design. But again, the core of this, the most important piece to know is that when you go self-insured, you're basically saying, I'm the bank account. And so because of that, because you're actually paying out the claims, you now truly have an incentive as the employer to manage your employees' health in a better way. Let's talk about who they are. Self-insured employers tend to be larger employers. Now that is changing. And I think that's one of the most interesting things about the dynamics. Again, anybody on this call who has bought or purchased health insurance on behalf of their employees knows it is freaking expensive. It has gotten so expensive. And this year, the 2026 renewal season, this was the largest premium jump we have ever seen, I think, in the last 10 or 15 years. So just in terms of percentage, the cost and just through premium costs keep getting more and more expensive. And so as that happens, it's actually pushing the self-insured line further and further down market. So maybe 10 years ago, it would be uncommon to see an employer with less than 500 employees be self-insured. Now you're starting to see more and more. We're working with groups that literally have 60 lives that have chosen to self-insure. I have a friend that runs a TPA that helps really small companies self-insure. And so, again, there's more and more appetite to go down this pathway, which is really, really interesting. I think important for practices to understand.
And what is your view when you were discussing this with physical therapists, right? What do you think is the biggest misconception? What do PTs not understand about this model? And what do you wish they understood so they can start engaging with it?
Yeah. The first thing is that it's important to understand that there are two pathways into an employer. And I think most PTs only think about one of them. The two pathways are the work comp pathway, and the other is the group health or insurance benefit pathway. Okay. As PTs, we all understand work comp because we've been in and around this, right? Employee gets injured on the job, or a employer, a work comp or safety officer wants to try to reduce reportable claims, or they want to get way ahead and screen individuals. There is a whole suite of services and very well-established pathways to work and partner with an employer on the work comp side. And I'm not here to tell you not to do that. We think there are tremendous models to go down that road, tremendous pathways to do it, and we're seeing lots of practices have lots of success. But I want to just also open up everyone's eyes that is not the only path. And believe it or not, the work comp pathway ends up being about a third of the spend of what the group health or insurance and plan side is, right? So by only thinking about the employees that get injured on the job or employers who are trying to prevent those on-job injuries, it's important to note that their counterpart, who's just the VP of Total Rewards or head of HR or the CFO, is usually seeing about a 3x MSK spend exposure on their health plan. And there's other reasons to look down that group health channel, right? The reason for looking down that pathway is not only is it a larger spend on average, it's also a little bit administratively simpler to help employers bend the cost curve. And the reason for that is you're providing physical therapy care, right? These are individuals who, like myself, who was playing pickleball over a weekend and did a split, had a really bad lumbar disc herniation, right? I got hurt, needed PT. It's folks that are, your weekend warriors. It's all the people that are already coming into your practice on their health plan, right? You just think about what percent of your employees today are work comp versus not work comp. that alone should paint the picture, right, of the differences of percentages of folks that are needing care. So I'm just, if there's anything that we're trying to do with Second Door, it's just open eyes up to say, hey, there's a really, really interesting pathway to partner with employers here. And you can do so on the direct contracted group health side. Okay. We'll come back more to some of the challenges, but right now, again, want to kind of highlight that.
So then once you finally make a decision, right? If you are a PT administrator or if you are a practice owner and you make a decision like, this is for me, I'm going to start tapping into this bucket. Who is the contact person? Who do you go and see? Do you contact HR department? Do you contact the CFO organization? Like, what are your sources? Is there a centralized agency or is it just pretty decentralized? And you have to have an expert like Second Door that actually helps you align some of these.
Yeah. So look, I'll be the first to tell you guys again, what we do at Second Door is help practices with this model. We help practices in kind of two methods. We help practices by providing resources and tools to help you go out and do this yourself. But we also offer a services layer where we'll actually do all the heavy lifting and go out and sell. We know when we talk to a lot of practice owners, they're like, look, I do not have time to do that. But I might know Jim Smith, who is the head of benefits at a local industrial plant that is, my brother-in-law. We have an awesome example of a very large national employer who was a customer of ours, assistant baseball coach. He was the head of HR, right? So to answer your question on who to reach out to, when you're talking about the group health side of the business, it's a pretty small subset of folks. It's usually again, depending on the size of the employer, they'll have different titles, but it's usually the head of benefits, sometimes the VP of total rewards, sometimes you're talking to a CFO, sometimes even to a CEO of a local business who has exposure or awareness into their overall plan spend. And we'll talk a lot about the strategies, education, and the requirements there, but it's really important to find those people. Now, again, just to give you a little bit of a peek into what we do at Second Door. Second Door has a whole set of tools that help you prospect local markets. And then once you've identified employers that are geographically in close proximity to you, you can actually use our tool to find out if they are or are not self-insured, who their broker is, because they actually have a major role in this process, especially on the group health side. And then you can use our tool to identify who in the C-suite might be the right stakeholder to meet with. So those are all things that are discoverable now, thanks to the wonderful but creepy amount of information that's out on the internet. And we help practices tap into that local knowledge graph to understand it.
So on the reverse side, though, is there an ideal size of practice that will be able to tap into this market? Or are you looking for something that's like mid-sized, 20 plus locations? Or can you be a single site owner or have a couple of local sites and still tap into this market?
Yeah. The reality on this is size matters, but there is opportunity to participate no matter what. So here's why I like to think about this. And with Second Door, we're trying to close a lot of these gaps so practices of all size can participate. Let's say you're a one location practice and there's an Amazon distribution warehouse in your backyard. I wouldn't recommend reaching out to Jeff Bezos and trying to strike a deal, right? When you're thinking about who the perfect fit employer is for your practice, you want to make sure that you can have coverage over that area, right? Think like a benefits leader, right? Think about your own employees. If you're going to offer a benefit, you want that benefit to be accessible by all of the people that work for you. You do not want to create this kind of split benefit where some people can get it and other people can't. And so what that means is you have to be very thoughtful about looking for employers that fit within your geographic footprint. Okay. That being said, one of the things we do with Second Door is we have a network of almost 2,000 clinic locations right now in about 45 states. And what we do with that network is provide options for smaller practices who may have really great connections and a great local footprint to perhaps something like a headquarters to be able to go out and still go through a contracting motion with that employer, but expand your reach through a network of like-minded practices and through a series of kind of tools that we've put together to help manage quality and routing of patients. Okay. So again, I think the key piece to take home here is just making sure that you have a geographic footprint that's complementary. If you have a lot of gaps, probably you will not have the most success on the group health side, right? Because of that equitable benefit design need. That said, if you are smaller, but you have a good geographic footprint to a single distribution center, warehouse, HQ, absolutely nothing wrong with exploring the work comp side with those employer conversations, because lots of times there are plenty of opportunities there.
So why don't we zoom in then on a clinician preparedness, and specifically, it's a slightly different frame of mindset and practice when you're taking care of directly with employers. So what do you look for in terms of clinical skill set and a clinician preparedness to be ready to participate in this? And there's a dissonance when you are seeing commercial payers and then you're seeing direct to employer payers. Have you seen this model work in a clinical setting?
Yeah, every practice we work with treats both, right? So I think what's really important to note is like, what are you selling to the employer, right? Like, what is that employer looking for? And remember, the core thing you are selling the employer is a way to steer employees to a low-cost starting point of care. The biggest predictor of longitudinal cost with MSK is where they start care. And so you want to make it really simple, really efficient. You want to take away as many barriers as possible to getting somebody into care. Now, we have some friends, some friendly competitors that have built very, very big businesses under the thesis of the best way to do that is through virtual delivery. And I'm not here to beat down on virtual. I think there's great places for virtual care to be delivered. I think it is a valid and viable treatment option, and we are supporters of that model. But what we also know is that it gets very low utilization across an employee base when provided exclusively, when that's the only option. And so it's really, really critical to partner with employers to provide ways to drive that local, trusted, hands-on care provider. And that's ultimately what you're selling, okay? You're selling access, and you're selling access to local, trusted care providers. Now, I like to keep things simple because so many things in this world are complicated. I tell people, look, you are providing physical therapy. You don't have to overcomplicate this, right? But you are not going to sell the employer physical therapy, right? You're going to sell them an MSK management solution. And what an MSK management solution will do is utilize physical therapy as a modality of treatment for managing these MSK conditions. But again, what you're selling is access. What you're selling is the ability to provide data and insights into the folks that go down this pathway and are they actually helping save money. You're providing an interface and a way to streamline the ability to do business with this employer so that it's really, really simple for them to send employees this way. And then ultimately, you're there to be a consultative partner to help find additional areas for value, right, which you can expand on. A lot of times that means exploring the work comp side of the business and finding other inroads for participation with that employer. But again, you're providing PT, and you're just trying to build a conduit to make that access to care really, really easy.
Ultimately, if you're a good clinician, you're a good clinician everywhere, right? You don't have to be a good clinician only for employer space or only for conventional space.
This surprises a lot of people, but one of the most common questions I think customers of ours ask us when they come and they say like, well, employer XYZ, they are already in network with Blue Cross. They use Blue Cross as their TPA or their ASO provider. And I'm in network with Blue Cross. Why is this employer willing to pay me a higher rate? Because undoubtedly, I will tell you, direct contracting yields pathways for substantially higher rates. The reason they're paying the higher rate is because they're incentivizing access to care. In a lot of cases, they're redesigning their benefit. They're doing a carve out for this particular program. They're waiving copay and out-of-pocket cost sharing for employees where applicable. And again, they're paying you a premium to manage that care efficiently and early, which is ultimately the name of the game. And if we can do that and make that access accessible and make that experience great, you have a great opportunity to reduce the downstream cost.
Is there a specific knowledge base that you would recommend for clinicians to brush up on, like specific to healthcare economics that goes a little bit away from the clinical side, but more towards a economic side? So is there a specific type of knowledge and then a repository of this knowledge that you recommend handling?
Yeah, I think this is the balancing act of, when I think of like a well-rounded holistic clinician, it's one that can be pragmatic in the integration of fantastic clinical care delivery and fantastic customer service, right? And ultimately, I think the other angle that if we're truly looking to provide excellence in this model, you have to start working your way towards a primary care first approach, right? And you have to think of yourself as that primary provider, because in almost all instances, right, this is as direct access can get. The whole goal is to have you be the first point of contact for these MSK conditions. And so when we think about, clinical competencies and how you continue to raise the bar, ultimately the better your providers can get at managing a patient in a sort of a primary capacity, the better positioned you are to have lasting, sustainable impact, especially on cost. But I also like to be pragmatic, and I'll point this out, and I will say this, and our friend Zach Walston, who's our head of clinical, will grind his teeth and disagree respectfully. We actually agree on this one, but I also think it's okay to keep it simple and provide great PT, right? Because again, at its core, what every data point we've looked at shows is if you start in PT, you have a lower longitudinal cost versus if you start in the urgent care versus if you start in the even primary care's office, and especially if you start in the ortho. So this is why I say, we do not require, or even in a lot of instances recommend, a broad clinical training program to get started with this model. We tell people, look, work on developing those pathways and those direct contracts. And then over time, you can continue to deepen your ability to kind of be that first point care provider.
Yeah, and to give a shout out to, I think, you are the creme de la creme clinical provider, like with Second Door, because Zach is probably one of the top clinicians in this country and one of the top researchers. So it's a spectacular talent that is working with you to actually create these models that are, going to be valid. So
he's the man.
Oh, yeah, by far. So, and shout out Zach. So is there a specific employer, specific organization that you have run across that you would actually recommend against contracting with? So are there any outliers that you would steer away from based on your experience and based on your exposure?
Yeah. So if you're trying to sell on the group health side of the business, first things first, I would avoid anyone that's fully insured. Okay. It's probably going to be a waste of time. We have seen success stories where there still have been great partnerships. But when somebody is fully insured, it means they're, paying the premiums, right? They're not the bank account. So the alignment really isn't there. If you're going to break my rule and you're going to sell to them, the thing you're selling them is experience, right? You're focusing on employee experience, and you're basically just going to say, hey, we want to offer this as a courtesy to your employees. We've seen customers of ours basically get paid to market to a set of employees. But that really is kind of the extent of it. But it's typically not worth your time of selling down the group health pathway. The other thing I would just tell most practices to probably avoid are unless you're collaborating with Second Door or we're kind of leveraging the broad network. I would not try to sell too hard to employers that have a ton of employees outside your coverage radius. Just because, again, you will just find that you cannot effectively solve that network adequacy challenge, and you don't have a really good story for how you can provide care to every employee in a consistent and nearby way. You're going to have a challenge. Now, you can do that with telehealth. Like it is doable and possible. But we have not seen the success rate be very high. Whereas, folks selling to a local municipality, a college or university, a local police and fire department, a local school district, those employers that have a really tight geographic density of employees and those that have people who live in and around the communities you already serve, totally different story. That's a great fit and definitely ones to focus on. Also important to note, basically every municipality in the country is self-insured. So it's a great area to at least start and start exploring.
That's actually really interesting. So what is behind this municipalities being self-insured? Is it more political? Is it more?
No, I think it's a really good question. I haven't, I think at the end of the day, it's because it's more economical. I mean, while we can all complain about where our taxes go, I do think in a lot of parts of the country, for anybody who's worked in and around government, budgets are not always gigantic. And no matter what side of the aisle on, we can all gripe about how they get spent. But it's no surprise that healthcare costs have a really, really big impact on municipal budgets. And so they're always looking for ways to control healthcare spend. So, I think again, just points back to it's a more economical model that employers have known for, 3-4 decades, and we're continuing to see more and more adoption of.
So let's go a little bit deeper then into the outcome measures and objective measures and collecting data. And so just more on the N=1 experience. Most clinical sites that I have been a part of didn't do ideal job collecting outcome measures, didn't do optimal job tracking clinical data, right? So we start off well, but then we somewhere along the way lose this side. So what do you do to standardize the process of this data collection? Because it's important. Also, what do you do to train clinicians to become a little bit more data oriented instead of just being clinically oriented? And what have you seen work so that we can run it across the enterprise?
Yeah. So again, let's start with why on this one and kind of work our way back down to that. Again, you're selling a premium experience to the employer. They know that they have an MSK cost problem. They know that they want to try to modify it. And the way they're going to modify it is by incentivizing folks to utilize a conservative first starting point. You got to tell them why you're better, right? And they're going to want to know about your quality. It's really, really important. If you don't have a way to tell that story, you're going to have trouble. But I'll note, clinical quality is not the only benchmark that these employers are looking for. And it may be frustrating to both Zach and I, and I'm sure you too, Alex, like it's actually kind of rarely brought up as the first point of conversation, right? And I think that's for a couple reasons. One, I think when you are a local trusted brand and an employer knows you because you've been in a community for decades and their brothers come to see you and they've sent their kids to see you, they know you have a great reputation in that community, right? And so that carries a lot of weight. And ultimately, I will say the number one problem that's being solved for first, remember, is access, right? We are trying to get people as efficiently into care as quickly as possible. So outcomes is a important and becomes progressively more important data point. While it may not be the thing that stops your ability to procure the contract, it will 100% be a reason you do not renew that contract if you don't develop a good outcomes and data capture strategy. So broadly speaking, to kind of what we've found and what we continue to try to help with, and we always recommend working with great EMR providers who also help with this. You want to try to put your outcomes capture on autopilot, right? One way or another. And you want to be really thoughtful, but you gotta basically make sure that it's being sent to as close to 100% of patients as you can. And you got to make sure it's sending follow-ups regularly and you get those follow-ups as close to discharge as possible. There's a lot of great solutions out there for doing this, but also there are ways to do this for incredibly low cost. We offer an outcomes platform that we do not charge money for because, again, we understand the importance of capturing outcomes throughout the overall data story for what you're trying to build. Ultimately, though, I think access, patient-reported outcomes, and then patient experience probably are the holy trinity of what you are trying to paint the picture back to the employer, especially once you have one of these contracts and you're trying to show that it's working really great, right? So we get people in quickly and we're getting a good percentage of their employee base to use it. Benchmark that we usually shoot for is 7 to 10%. Digital companies tend to only get about 1.5 to 3. So this is one of the big areas you can differentiate yourself by being a local provider. That local hands-on care is adopted at a substantially higher rate than these digital-only solutions. You can tell that through access. Again, you want to show that pain is reducing. One kind of sleeper good outcome assessment that I don't think enough people are thinking about is surgical intent, right? So surveying the things that have a pathway or a potential to drive high cost. If you can tell an employer that every person that came in to see you had a high surgical intent when they showed up at eval, and now their surgical intent is substantially lower, ooh, that is gold, right? That is gold from a data standpoint. It's proving the value you're providing. Remember, the hardest part for this, you have to prove a negative, right? So you have to prove that you participated in a surgery not happening. And so surgical intent data, pain reduction data can be really, really helpful. Functional improvement data is obviously huge. But again, that final piece, like employers, especially as head of benefits, they also just want to know that their employees liked it, that they had a good experience, that they felt well cared for. And so again, net promoter or some form of patient sat, critical in a sort of well-rounded data structure here.
And I think it would be like, it's so important to mention that most of us are focused on patient outcome measures and specific outcome measures, but there's also experience measures that can be standardized and objectively collected. Right. So you can standardize patient experience measures, like Net Promoter Score being one of them, but there's more granular tools. And you can still show this to the employers that, look, we're providing a superior experience. And for that, like, we obviously deserve to earn your trust. So let's go.
Oh, can I say one thing here? Can I say actually one more thing before we move on? Because this is one of my pet peeves that I have to get out there, and this is going to hurt some egos. But I think it's important to just let this thought die for a second. When you're going out and selling to the employer, like the initial sales pitch, they don't care that you are theoretically better than the clinic down the street. Okay.
Yeah.
We need to drop that mindset basically entirely, because they don't know the specifics of PT like you do, and they will care. You'll get them to care, but they don't care at that moment in time. Just gonna be the first to tell you. So we've watched a lot of practices go into an employer sales pitch to pitch the very specific nuance of how they put their hands on the patient in a specific way and how that yields these superior results, or why their treatment model and one-on-one care delivery is better than some other practice down the street. Nope, you're fighting the wrong battle, okay? You are up against the orthopedic surgeon, the urgent care center, the primary care doc that has a high likelihood of sending them somewhere that's going to drive up downstream cost. That is it. That is the name of the game. And so you want to provide a lot of confidence and conviction that you're not going to cause that downstream cost to balloon. So anyway, little pet peeve thing, but important to call out.
No, I mean, it's right on. Like, it's like the old joke, right? How do you know somebody went to Harvard? Like, they'll tell you. It's the same with clinicians. I think we all carry that we're better on our sleeve, except that it matters to you potentially as a clinician. You should try to be the best that you can be. But to the employers who are looking into just the MSK cost, the cost revenue is king. So you have to know the language, and you cannot expect somebody else to adjust to your language. You have to adjust to their language in order to make ends meet. So let's discuss then a little bit what you just mentioned. And I want to go back to that digital care engagement being so critically low compared to the in-person engagement. What is behind the low engagement in digital processes? Is there a way to create more of a hybrid solution? And is there a way to use, obviously, because we're an EMR provider, we're an EMR technology firm that has been built on just the fundamentals of this advanced technology. Is there a way to encapsulate all of it through this central operating system that is what we do?
Yeah, no, it's a great question. You know, when we look at why, it's really interesting, and I want to just like first off say there are digital providers that I think have historically made a name of critiquing in-person care, and I think there's a lot of in-person care providers that have made a name of really criticizing the digital groups. And I actually think we're gonna see a blended model and a unification continue to proliferate, where I think we can both acknowledge where there's pros and cons, right? But here's sort of the facts, at least as we've been seeing them. First off, it's just hard to get an employee to use an employee benefit. If, again, anyone on the call, is it even loosely inside of an HR function, or has been in the process of procuring a benefit that you provide to your employees, and then you look at the end of the year, how many people actually use that thing, you like weep inside, because you're like, man, we spent all that time picking that thing out and then nobody used it. And I think, unfortunately, that's what happens with digital point solutions, is they kind of fall into a basket of options that people have. We have like a really great second opinion service that we offer to our employees, and a great care navigation service. And I legitimately don't know if any of our employees have ever used it. Maybe one has. And I think that's just the hard part about these digital solutions, is they're not integrated into your day-to-day. what a local practice has as a huge unique disadvantage or advantage, is their local connections to local referral sources and that trust in the local community, right? It's very important to educate. We do a lot of the exact same things that digital-only solutions do. But at the end of the day, because you have that trust in that local relationship, if you can solve the access, convenience, and cost barriers, which again, you can do all through a direct contracted model, you have an opportunity to drive up utilization rate substantially higher, which means you have a much broader surface to bend the cost curve, which is great. So at its core, I think that's what we're seeing, that trust. If you can solve the convenience gaps and solve the cost gaps, you're going to net out in a much better place.
Yeah. So what are some of the mistakes that you have seen clinicians and clinical practices make early on or midway through these encounters? And how do you prevent these early mistakes from occurring so that you can start on the right footing?
Yeah. The two biggest mistakes are selling to the wrong person and or the wrong company. And then that's one. And then 1A is selling the wrong product. Okay. So first and foremost, we talked about this, but again, you want to find a self-insured employer. That's really, really important. While tools like Secondor exist to help you identify who is self-insured, if you just start off as a rule of thumb, if they're over 500 employees, assume that they're self-insured, right? If they're a local municipality, assume that they're self-insured. If you sell a fully insured group, you're probably not going to care. If you sell the wrong person within a fully insured group, they're probably not going to care. If you sell what I've been describing in terms of a solution that drives folks to use physical therapy more, and you sell that model to a work comp or safety officer, you're going to have a really hard time because they do not want that. They want the exact opposite. They want less people to use PT, but they want more preventative avoidance solutions and more of the kind of first aid style model. So you got to know your stakeholder, who you're selling to, and then what you're selling them. The other piece talks about it earlier, but when it comes to what you're selling them, again, I can't stress this enough. It's the hardest thing to do for practice owners, but do not sell them physical therapy. They're not looking to purchase physical therapy. They already believe they bought physical therapy. They recognize they have that as an in-network benefit under their health plan, right? You are selling them an MSK management solution. That solution, again, is focused around access, and it's focused on data and partnership with that employer. And ultimately, you're working with them to provide a premium access experience at a premium price with the intent that driving folks to this conservative first pathway is going to reduce longitudinal or downstream cost. And again, for anyone who's done this, we've seen remarkable cost savings numbers under this model, which is really, really cool. So I think that's the biggest place to start. In terms of like some of the other just items that were on there, like don't overthink care delivery itself to get started. It is still physical therapy under the hood. You are still getting folks onto your schedule to provide great care to them. Okay. But you are going to want to think about how you're streamlining that access. And then you're also going to want to make sure you understand the nuances of contracting, which means like, what do you do about high deductible plan members? And what are some of the gotchas around that? How are you going to partner with them, their TPA? How will this intersect with your in-network benefits? All those things you're going to want to make sure you've got kind of figured out beforehand. And again, that's all kind of services that Secondor can help with if you're looking to learn more on that front.
So is there a specific roadmap that you would line up? Like, so how long does it take for someone who makes a decision, contacts the employer, contacts Secondor, and actually executes? Like what, from the decision to actual implementation, what does a typical roadmap look like?
You're not going to like this answer, anyone on this call, but here's the reality. We'll be direct. It can take a long time. Benefits buying cycles are awful. They're typically thought about in an annual basis. Again, I could go back to anyone on the call who's purchased healthcare or purchased a health insurance plan for their employees. How often a year do you think about it, right? You probably have planned for it once a year, and then you do it, and then you move on to everything else you got to do in your business, right? Solutions like this get bolted on. And so you have to meet people at the right point in their buying cycle. We've had customers get contracts in less than 4 months. We've had customers get contracts in 2 years. And we've got customers that we've worked for over 2 years getting to contracts. These things can take time. So you have to kind of plan that out. That said, it's never too early to start. And the way that you start is building relationships. One of the models we found work really, really great for local practices is to do an inventory of some of the key personnel at your business and start asking the question, who do you know locally? We have tools, but you can just use Google, find the local larger employers in and around you and say, hey, do we know anybody that works for this company? It doesn't have to be the CEO. It doesn't have to be the head of benefits. We've had groups that literally knew somebody that worked in facilities that was able to connect us to their HR and benefits leader, and that was all we needed. So building those relationships are really important. Building relationships with brokers are also really important. We won't have enough time on this conversation to go deep on brokers, but just know that lots of employers make buying decisions around benefits based on what their broker tells them to do. There's a lot of trust in that relationship. And there's a perverse incentive structure with brokers. And so there's a lot of complexities around there, but they're a really important piece overall.
Yeah. Trying to circumvent the third party, you're actually dealing with a third party, right?
Yep. But a lot of times, well, they get paid by the third party, so you got to circumvent them very carefully. How about that?
Absolutely. I think there's a lot of cooks in that kitchen. It's not always one cook that makes that decision. So I'll go ahead.
Yeah. Do we want to talk about pricing? Because I know we've got that on there, and I think this is maybe the number one question people ask is like, how the hell do I price something like this?
That's right.
So we had a slide earlier, right? Because a lot of people think about like direct contracting. Is this fee for service? Is it not? I'm here to tell you, like, you can structure this as a fee for service contract, right? Essentially, every group we're working with right now, at the end of the day, has this as essentially a fee for service model, almost always a per diem rate. So they're not worried about units, but it is just a direct contract with a negotiated rate. We tell groups, when you're going down this pathway, because of the opportunity you have for shifting costs. I mean, this is just such a high cost area, and PT is such a good starting point. You have just this great opportunity to bend the cost curve that you really can, be more aggressive when you price this. We tell folks at minimum 120% of Medicare, right? It's kind of like where you want to try to land with these price contracts. We've seen folks go substantially higher. We've seen folks accept lower. But ultimately, you want this to be in the top quartile of what you're currently, being paid. If you're an out-of-network practice right now and you're used to 200, 300% of Medicare, I'm here to tell you, you might have a hard time with that. It's not impossible. We've seen folks do it, but there is a price cap. While there's not a massive amount of price sensitivity, there is a price cap of what you can do. And at a certain point, when they say, well, this is twice as expensive as our in-network provider, you're going to have a hard time, right? You're going to get tougher sledding. And or at the very least, you better come with some really great data that shows why, you're going to do this better than anyone else. But we have not seen that be wildly successful. So it's just an important one to keep an eye out for. So again, and then we see people typically do, there's a lot of pricing models, but we see folks typically do a visit rate. Some folks have explored case rate contracts, which I like a lot. We've seen other groups do a combination of visit rate and percent of upside on shared savings. Really cool what you can do under that model, and a huge opportunity for a ton of value. But I will warn you, don't start there. For multiple reasons. It's going to slow your sales process down. There's a lot. You are taking some amount of risk in doing that. And I would be very hesitant to do it with small employers, just because there's always the potential for the outlier that you had no control over. The larger the employer, the more tolerance there is to exploring some of these more risk-based pricing models.
What does, and this would be, I guess, my last question, but what does a well-structured direct-to-employer line look like to the bottom line of the practice? How much revenue can it actually add? And can it be a difference maker, or is it something that just puts a little cream cheese on top of the bagel?
Well, I'll tell people, you're not going to magically have this be 50% of your case mix overnight. I mean, we would love for that to be the case. And when you work at it, you can get there. But you sort of have to work your way backwards. So the kind of like basic calculator that I have people, and we've got one we can send your way. But essentially what you got to think about is how many covered lives are you contracted with? What actual utilization percentage are you expecting? So I tell people forecast 7 to 10%. We've seen people lower, we've seen people higher. And then from there, that's the number of new episodes, right? If you're at 140%, 150% of Medicare, and you've got a 10,000 life business that you're getting 10% of, that's a nice little line of business, right? You'd love to see more of that. Where we've seen folks make the most impact under these direct models is the compounding effects of getting a contract. Because what ends up happening in practice, we didn't talk a ton about brokers today, but what ends up happening is the broker for that employer sees the success that you're having with that employer. They immediately pattern match and go, ooh, I need to bring this to my other self-insured employers. Now you have a broker doing the sale for you, bringing you into deal after deal after deal. That's the compounding effect of direct to employer. So this is not a get rich quick scheme. We would never sit here and present it as such, but it is a take back control scheme that gives you the optionality to start building these direct relationships, using those to build more direct relationships. And then at the end of the day, you sit in this really interesting place where now you're partnered directly with these employers. You're being paid outside of the health plan through this direct contract. And you really have a great opportunity to start to push back on some of these more predatory reimbursement schemes that are out there. Gives you a lot easier pathway to start thinking about saying no.
Absolutely. And ultimately, it would we both would agree that physical therapy at this point in the United States is vastly undervalued, regardless. I think we just, and thank you for what you're doing on your part in Second Door to increase value and to increase viability to our services. So I'll open the floor for questions from the audience. And we already have one question, which is APTA has a primary care PT chapter led by Katie Albright with great resources. Very important to brush up on screening and triage and direct access. Is there something that you have explored about these competencies that are APTA driven towards fulfillment of the direct employer access? And what would you comment on it?
Yeah, 100%. Katie's amazing. Got to meet her in person at CSM, and huge shout out to the work she's doing. 100% would recommend any practice take a look at that when it comes to building competencies of your treating therapists. But I'll also say that for folks who start down a direct to employer contracting journey, there are way more barriers in the business to business relationships that you'll run into first before you even get to the point of having to modify or enhance clinical care delivery. You've got to build those relationships. You got to do the legwork of doing the outreach and sales process. You have to make sure that there's alignment. You have to slug it out with the brokers and go through RFP processes. I'm making it sound awful. And it's not, but it is work, right? Companies like Second Door exist to help you sludge through that. And we'll take on a lot of that kind of legwork to participate in these contracting opportunities. But again, it's a pathway to go down. So I would say feel free to do them in parallel. I think it's totally the right way to go. But just recognize there's going to just be the practical macheting through the forest first to kind of get to the pasture where you can start to take advantage of the kind of augmented service delivery.
And I would agree. I think Katie is terrific. She's definitely structured a solid direct primary care PT model. Yeah. But I think you have to understand even the fundamentals, right, of how to provide good experience. And I think a lot of it is on the employer side. So this question will be for me, actually. And I know you mentioned this a little bit earlier, but the downstream effects and how poorly PTs understand the overall impact that they cause, including reduction in surgery, reduction in downstream healthcare utilization. What have you seen from Second Door perspective, and how has that influenced the communities and medical community in general?
Yeah, we are sort of at the point in the broad, I would say, employer community, talking to benefits brokers and employers, where it is essentially just fact now. Like, no one contests it, that a conservative first starting point to care yields a reduction in downstream cost. And whether it's, the work that Julie Fritz has done or so many others in the kind of like health economics of PT, especially whether that's showing the longitudinal cost reduction of, compliant treatment of low back pain, or whether it's, what we've seen even from folks like United Healthcare on the differing in longitudinal care costs based on starting point. We've seen tremendous results. And I think what's been the most optimistic outcome that we have seen is the surface area for impact of this in-person model, which I think so many folks have written off in the broader kind of health tech ecosystem. Everyone says, let's just build an AI bot and create a whole new care org that disintermediates hands-on, local, trusted care. To me, I'm like, that's the same people that have been telling me the death and demise of email or the freaking fax machine, right? Like, healthcare is local. Dave Chase over at Health Rosetta, has an amazing book, called Healthcare's Local. And we all know it because we're consumers of it. When it comes to kind of managing care, we want trusted relationships with the best local providers. And it's why we're just so bullish on solve the access and connection gaps, but you don't have to change the care delivery model. So when you've got that, and again, it's why we love working with local practices, just because there's just so much upside and so much opportunity here.
I think we definitely should also highlight that there is something that's called domain expertise, right? And Second Door is a domain expert in this space. Spry is a domain expert in EMR, revenue cycle management space. And so there's always going to be others that try, or you can always take that, I can do it myself. I build versus buy mentality. But domain expertise is such where you have to trust experts like Scott, or experts like Spry that do things well. So we only have a few minutes left. Is there any parting points that you would want to strike here that the audience can take with them?
Yeah, I've said this in a few talks that I've given, but it's still so important that I think just needs to keep being said. Practice owners have a lot. I do not envy you guys. It's a really hard time to run a therapy business, but it's so important right now. And there are so many competing priorities that pop up every single day that maybe the thing I've heard the most from the most practice owners is we've been thinking about this direct to employer thing, but we just haven't had the time to go out and do it. And all I will say is if you keep letting that be the excuse, somebody else is going to do it for you. So don't let that happen. While the road can be challenging, folks like us, folks like the APTA has put on some great programs around this. People like Tim Spooner is doing some awesome stuff with Solve Global. There's so many people that are doing amazing programs that are helping practices go out and work directly with employers. That you got to go take advantage of that time now, and it's truly just a matter of sticking with it. The practices that are yielding the most revenue from this are just the ones that got started before you did. There wasn't anything remarkably different about them. They have just chosen to prioritize this and put the work in, and it's created these just great new revenue streams for the practice. So hardest step is the first one, and we're here to help make it easier to take that one.
Absolutely. And I hope everyone who is on this call, and this call will be recorded, and it will be hosted at the Spry website. So do not fret if you haven't joined immediately. You will have the ability to contact Scott, and you'll have the ability to find the recording to this. But Scott, thank you for everything you do, and thank you for moving the needle, definitely moving the needle through your career and now with Second Door, being a change maker. So with that, I think I'm highly optimistic about where we're headed as a profession. And thank you again for where you are and what you do. And I hope to see you again soon at one of the conferences.
Thanks, Alex. Appreciate you and Spry making the space for us to have this conversation. Appreciate it.
Thank you, guys. And thank you everyone for attending.
See you guys.